Hi there, this is Dr. Alice Lee. Welcome to this month's iCubed. iCubed is Emergency Medicine News' latest blog this year, and I'm really happy that you've joined us. This month I have a dear colleague. I love working with Dr. Ottney. Welcome to iCubed.
Thank you, Alice. Thank you so much for inviting me.
Oh, you're welcome.
I'm Elizabeth Ottney. I am an emergency medicine physician in Arizona. I've been working with Alice now for 6 or 7 years.
Yep.
In the same hospital with our very, very interesting cases.
Yep.
I think this is a fantastic thing that she's doing, and I'm happy to join her.
Oh, terrific. So, Elizabeth, where did you train? Well, give us a little bit of your background.
So I attended Arizona State University for my undergraduate. And then I went to medical school in Kirksville College of Osteopathic Medicine, now renamed AT still. After medical school, I went to Maine Dartmouth residency program in Augusta, Maine. After residency, I then started serving my military obligation, scholarship obligation back. And I went to Fort Campbell, Kentucky, which is home of the 101st Airborne. And that was in the year 2000, exactly 1 year before 9/11.
Oh, wow.
So I was on the post 1 year before 9/11 occurred. And so the entire 101st Airborne spent the next 2 years deploying and preparing for Afghanistan and also Iraq. So in 2003, I deployed to Iraq for a year.
Gosh, that's amazing. Well, I'm sure you've been told this, but thank you for your service. That's remarkable. I did not realize the extent to which you served the country. Thank you so much.
Thank you.
Well, let's just jump into this case. This is a lady I saw 5 months ago this year in our very busy emergency department. She was a 56-year-old lady who had a history of atrial fib, and she had a previous small stroke, not having much deficit. She came in by ambulance, brought in by her husband. He said he had got out, and then when he came back, he found her on the floor about 1 o'clock in the afternoon that day that she presented. He told us that she had fallen while they were hiking a week ago, and they had gone to another hospital locally for her injuries. She was diagnosed with a couple of rib fractures, 10, 11, 12. And in fact, she had a spleen bruise, is what they said. So she was kept overnight, and they sent her home. Now, the patient tells us that she was taking a pain pill and a muscle relaxer, and that she felt faint from those and was feeling, that maybe she was being affected by those medications, and that's why she fainted. She also was on Xarelto because of the AFib, but had been taken off of it for this past week. Okay. Any thoughts so far?
This is a very interesting case because it has you going a lot of different directions.
So what are you thinking right now already, just with this little history?
I mean, I'm very concerned about the splenic contusion.
Sure.
So that's, and somebody that was on a blood thinner, even if only, stopped a week ago. But it always concerns me when someone is found down because you don't have any good history to say, oh, it looked like a seizure perhaps, or, they stood up quickly and got lightheaded and then they went to the ground, or they weren't able to tell you anything. Wow, my heart's really beating fast before the event occurs. So she's found down. So that's just a
mystery syncope, right?
Yeah,
so you're right. You're absolutely right. I think that those little details, I've always said this, the devil's in the details, but those little details, historical details, are so critical in what we work up, what differentials we think about. So yeah, definitely this is a worrisome case right from the start. In fact, I'll tell you, when I went to see this patient in the orange zone, the nurse said, oh yeah, she just passed out in the waiting room. So I go into the room right away when I hear that little bit about her fainting in the waiting room. So I but I go in quickly. And so on general exam, you look at her vitals. They're actually pretty good. Blood pressure is 112 and the heart rate is 82. Respiration is a little bit up at 24. Her sats are okay on 2 liters. It's 100%. So just looking at general exam, she's laying down on the gurney. She's supine. She's in severe pain. She's hyperventilating, she is anxious, she's pale, she's able to converse with me. The husband's at the bedside. Okay, so you get this mental picture of what she looks like in general. There's no signs of trauma in her head. Her skin is, like I said, sort of pale. There's no tenderness in her neck. She's just has her arms down on the side. And on exam of her chest, There was no crepitus, there's no deformity at all, but she is definitely tender over the area where they reported that she had rib fractures. The area of concern, obviously, is her abdominal exam. So she's pretty flat abdomen, but she's really, really tender all through her abdomen, all over, not a specific area. There's no guarding and there's no rebound, but she's very, very tender.
I find this interesting that this is a case that we're worried about this patient. We have every reason to be worried about this patient because of her history and because of her most recent events, yet her vital signs are stable.
Exactly. What do you think next? What are we doing next?
There's a lot of potentials that could have caused her syncopal episode. I mean, she is a patient with a history of arrhythmia and things like this, and these are all might be an explanation, but first and foremost in my mind is still that splenic contusion.
Of course.
And she's on the, or had previously been on the Xarelto. So at our facility, we have we're a level 3 trauma center.
Right.
Calling trauma activation would get a lot of resources at that bedside very quickly.
That's a good option.
And get immediate reads to any scans that we might want to do. Bedside ultrasound is also available to us. And so that might be if you're thinking that the money's in that spleen,
right,
with a sore belly, and her history. The other thing is that she also fell a second time. So she fell while hiking a week ago, and then she fell again at home. And so maybe with her normal vital signs and her tender belly and her tender ribs, this is just somebody who fell a second time. And re-injured that area, and so she's got a lot of pain, but her vital signs are stable. She's on the muscle relaxers. Maybe that is what's making her dizzy and fall with ease, but you just don't know.
Right. For me, in this case, it was a perfect situation for me to use bedside ultrasound. I have become a POCUS evangelist. I have become so enthusiastic about POCUS that I immediately thought of using bedside ultrasound and EFAST for this lady. So that day, ultrasound machine was full. I couldn't store the image. So I had to film it. And it's just really not a good quality film. But this is not the best image, but I'm looking at the right upper quadrant and looking for fluid, free fluid. Immediately, within seconds, I am seeing fluid in the Morrison's pouch.
That's a significant amount, too.
Absolutely.
That's not like something you would miss.
That's exactly right. So then after the right upper quadrant, I go over to the left upper quadrant. This is a spleen injury. I didn't know exactly what I would see for sure. But that's the spleen. And I'm pointing out to the PA. That's the spleen. And there's fluid around.
The dark shadow above.
Yeah. You can see the outline of spleen. And I apologize for the terrible quality of this ultrasound. The machine was full and it couldn't store. So then by using POCUS, I immediately know this lady's got a ruptured spleen, right? Because of her clinical history, she's got free fluid. It's absolutely a ruptured spleen. Labs come back. Her white count is 8.9. Her hemoglobin is 12.2. Hematocrit is 35.3. Her vitals were good, so I think that kind of correlates with that. Although we know with an acute bleed, the H&H is not exactly reflective of the true blood loss, right? The rest of our labs are really pretty unremarkable. So we get a CT scan right away, and the CT report, AAST grade 2 splenic fracture with stable large perisplenic hematoma in the small to moderate hemoperitoneum. There's an acute fracture of the left 7th, 8th, 10th, and 11th rib. There's 4 rib fractures on this poor lady. The AAST is American Association of Surgery for Trauma. I don't know about you, Elizabeth, but I love looking at the CAT scans myself when there's a positive scan, right? So I initially ordered a non-con just because I wanted to get it done quickly and get the patient either to the OR or to just the surgeon right away. There's a few interesting findings on this scan. First of all, obviously you see blood, right?
Definitely. You can see that nice shadow.
Nice shadow. And that's where you would find the, blood in the Morrison's pouch. And then as we look for the spleen, look at that thing. It's just mashed potatoes.
Wow.
Right? Yeah. So this is the coronal view.
Mm-hmm. There again, you can see the hematoma there.
That's the free fluid around the liver. So then you see, it's just remarkable how much the spleen is just smushed in there, right? Mm-hmm. You really lose kind of the definition of the spleen. So then I call the surgeon, of course, and they want to contrast the study. Fortunately, the patient is stable, and also, we'll talk about this later, but splenic injuries are managed mostly conservatively now. It used to be pretty automatically splenectomy, but because the patient is stable, we went ahead and did another scan with contrast this time. So here is the coronal view with contrast. Remarkable. And it's pretty much the same. Mm-hmm, you just see the definition of the hematoma better.
But not seeing any active.
No, there's no extravasation. That's a very good point. I call the surgeon. They take her. She's very stable. They admit her upstairs. I followed the patient's hospital course, and they simply observed her. They did not perform a splenic artery embolization. They did not do a splenectomy. She lost a couple units. Her hemoglobin dropped from 12 down to 9 the next day, but it stayed about that 9 range. So, Liz, thinking back on your trauma experience, have you seen any significant splenic injuries, or is it just part of multiple trauma?
I had a very interesting splenic rupture, and unfortunately this man died. But he was an elderly gentleman who was a woodworker, and he had some kind of skill saw or table saw or something that he was working with, and he had a 1x6 plank of wood that he was pushing into the saw, and I don't know anything about these types of things, but anyway, how it works, and he got kicked back. So the board came back, struck him in the left upper quadrant of the abdomen. He waited about 6 to 8 hours before he came in to see us because, it wasn't too bad. He thought it was going to get better. But by then you could see the ecchymotic lesion that was of dimensions of 1x6. I mean, you could see where the end of the plank had literally hit him square over the spleen. And so we made the diagnosis immediately. He was actually hypotensive when he came in, so there was no question that he was potentially unstable. Obviously, I think he had a blood pressure just under 90 systolic. And he did go to the operating room immediately. One of our fabulous surgeons who's not here any longer took him to the operating room immediately, did the splenectomy, and then in less than 12 hours he coded on the floor and postoperatively. And I think he may have coded more than once, but he didn't survive the code after that.
So with each iCubed screencast, I do want to focus our learning points to just 2 if I can. The first learning focus on this patient, obviously, is a delayed splenic rupture. It's a very rare entity. I have had one previous case in my career of a delayed splenic rupture where the trauma was a week or so, something before, and that other case I had. And this lady, the trauma was a week before. So I immediately thought of this case as a delayed splenic rupture. I did online search on the literature, not a comprehensive one, but I couldn't find a whole lot of information on delayed splenic rupture. But one of the ones I found was very interesting, and maybe because this article came out of Taiwan, my native home, it is more interesting to me. But it was published back in 2012, and it was really a single center retrospective study. And let me just spend a little bit of time going through it because I think it's instructive. They had 15 cases of delayed splenic rupture in about a 2-year period of time in one of the major trauma hospitals in southern Taiwan. So they immediately took all the unstable ones to the OR, like your gentleman, and performed a splenectomy. Out of those 15, 3 out of 15 were deemed unstable and needed to go to surgery right away. 12 out of those 15 they deemed as stable and candidates for non-surgical intervention, just monitoring. They took 5 out of those 15 for splenic artery embolization in an effort to salvage the spleen. One out of those 5 with the embolization procedure did not do well, continued the hemorrhage, and so they had to take that patient to OR for splenectomy. Therefore, 7 out of the 12 observed ones did not get the embolization. 1 out of those 7 actually wound up hemorrhaging again, and therefore they had to take that patient to the OR for splenectomy. So in this particular sort of isolated report, overall, they felt it was supportive of non-surgical management or non-operative management of delayed splenic rupture. They reported the success rate of 80% of the embolization, and then overall, they reported an 83% success for the non-operative management of the delayed splenic rupture.
Times have changed.
Yeah. I really didn't know a lot about delayed splenic rupture, so doing this case and researching it helped me learn and understand more about it. Delayed splenic rupture really is still very rare. And the question apparently was, well, are delayed splenic ruptures treated differently than your typical blunt splenic injuries? In the past, the blunt splenic injuries were always brought to the OR, and then you had a splenectomy. And then in more recent past, it's become, standard just to observe them. The question of whether delayed splenic rupture should be observed or taken to the OR was a second question, a different question. And it used to be the same as before. If it's a delayed splenic rupture, you would take them to the OR and perform a splenectomy. This particular article was just really supporting the fact, or supporting the practice of observing the delayed splenic rupture as well, which is commensurate with any other splenic injury. So this report is just supporting that, saying that most of their cases of the delayed splenic rupture was successfully managed by observation or by splenic artery embolization. So that's my learning focus number 1. Learning focus number 2, what do you think?
I'm not sure where you're going to go with it. Let's find out.
POCUS.
Oh, of course.
Yes, of course, you could have guessed that. Now, I just wanted to go through reasons for POCUS. This case, like another case of mine, another screencast of mine, just really was perfect for a bedside ultrasound. So I really would like to go through the reasons we would use POCUS. Number 1, it gives you a really quick answer. It's yes, it's no, right? Such as, is there fluid? Is there no fluid? Is there a pneumo? No pneumo. Is there cardiac activity? Is no cardiac activity? Have you done much ultrasound, Elizabeth?
Yes, we have done some. Banner Baywood particularly brought that to the bedside for us with phenomenal ultrasound machines and instruction by Teresa Wu.
Yep.
So that's been a huge benefit for our patients.
Yeah, just the other day, I had a patient that had come in coding, had been coded for a long time, and I can put the ultrasound right on the chest and just document truly that there was absolutely no cardiac activity, and we can stop the efforts, at that point. So it's time efficient. And then, so another reason to use POCUS would be that it improves the safety of procedures such as subclavians or thoracentesis if you're doing those, or paracentesis. Old dogs like us, our method was always sort of physical exam, right? Looking for the shifting dullness, looking for the pelvic bone, for the lumbar puncture. So POCUS can really enhance safety in these kind of routine ER procedures, right?
Absolutely. It's actually kind of similar to the glide scope. Now that we have that, we can't imagine intubating without it.
Right.
And those who come out of residency that have always had the glide scope don't know what it's like when you only have traditional laryngoscopy. And so in this particular case, now we have POCUS, and you never look back after that.
Yeah, definitely. I think it's just another tool, like many tools ER doctors have, we would put this tool in our box, right? Another point I've already mentioned, which is that using POCUS improves the efficiency of your throughput of your patient in evaluation of the patient. Such as the patient, I mean, I get a ultrasound and see right away within seconds that I've got free fluid. Next reason or another positive for POCUS is that it does improve patient satisfaction. Some of these patients are they're delighted by having rapid answers at the bedside. Many times I've done just a quick bedside pelvic POCUS to document the fetal heart rate, and the moms really like that. You know, they feel less nervous if you do a quick one. Another reason to use POCUS that it really is an extension of the bedside physical examination. For me, I became very enthusiastic about POCUS, partly because of that. You know, once again, you know, all of us who have been practicing for a long time are very used to physical examination findings and gathering historical details, and not as tech dependent as I think more recent physicians. So I find that the POCUS extends my physical examination. If I suspect, let's say, fluid, if there's a rigid abdomen or something, the POCUS really kind of confirms that for me in a very quick and efficient way. It is a non-invasive exam, and so that is helpful and less painful for type of technology than others. It does not have any ionizing radiation, therefore you're reducing the amount of radiation exposure to the patient. And it is one of those exams you can repeat, let's say here in the ER, and then maybe in the observation unit if you have to follow serial exams, for instance, or serial abdominal exams. Now, not everything is advantageous with POCUS. There are some downfalls. It is less accurate in morbidly obese people, and unfortunately we are seeing more and more obese patients nowadays. If you have patients that have ileus or cutaneous emphysema, POCUS really isn't the study of choice. You can't really tell what kind of fluid you see, even if you do see the fluid right away. Could it be just ascites? Is it blood? So POCUS does not differentiate the type of fluid you're seeing. And ultrasound, more than any other technology, is definitely operator dependent. So the learning curve is actually pretty flat. You really have to do quite a bit to be an expert or be very comfortable with it. The accuracy of the POCUS result is definitely dependent on the operator, the physician or the PA or whoever is doing it. And then lastly, the accuracy of your POCUS is sort of machine dependent. Earlier generation scanners just are not as accurate and not as clear. More recent generation scanners are so clear, so vivid. And I think there's actually more work being done on getting 3D ultrasounds as being more normal and standard. So Elizabeth, that was my case. What do you think?
That was a very interesting case.
Thank you. I'll pay you later for that.
It really was.
Yeah.
I mean, that's why we do emergency medicine.
That's right.
And when we get those interesting cases,
Yeah.
it's like you're a medical detective.
Yes.
But ultimately, once they leave your department, it's for the specialists in their fields
Exactly.
to manage that patient.
Exactly.
And that's not for us to decide, but we're the data gatherers.
Mm-hmm.
We get them their data.
Mm-hmm.
We tell them the story on the patient.
Yep.
We stabilize them and then move them to the next echelon of care, as the military would say.
Very
Higher
good.
echelon of care.
That's great. Elizabeth, it's been such a pleasure having you. I appreciate your time. We'll do it again, okay?
All right. Sounds like fun. Thanks
So-
a bunch.
Thanks everyone for listening and watching this screencast. We'll see you next time. I hope you learned something from our little conversation here, and we'll see you next time. Bye-bye.
Goodbye, everyone.